Marta, for your presentation of this symposium. I present myself briefly. I am not a researcher, I'm a clinician, and my presentation will focus the essential point of the clinicians to catch and do a correct diagnosis and treatment of bipolar mood disorder. First, it is essential to consider what the mood, what is the instability of the mood. The mood in a person who is euthymic is stable. What means the bipolar disorder? It means an instability of the mood, so that the mood swings between depression and euphoric irritability, and therefore there is an unstable mood. So that, again, a depressive episode is in fact one phase, only one phase of a broader bipolar spectrum in the mood, in which the instability is the main component. In this picture, I draw several modalities of instability of the mood, starting from the normal mood, going down to the depression, going up to mania, euphoria, and at the end, the mixed episode. In consequence of this, we can confirm that the bipolar spectrum disorder, all the spectrum, include the subthreshold form, are much more common than previous thought. For these reasons, a new classification of all the spectrum is essential to optimize diagnosis and treatment of this disease. Already, Professor Agius wrote this essential sentence to understand in what kind the approach of the clinician to treat the depression needed to change. Melancholia, as defined today, is more closely aligned with the depression and of the mixed phase of a bipolar disorder. Given the high suicidality from many of these patients, the practice of treating them with antidepressant monotherapy needs re-evaluation. I invite you to focus to this last word, need to re-evaluation. And Agius did a great scheme to diffuse and approach completely to all of the spectrum of bipolar disorder. I don't think anyone in this hall need to add anything to this perfect scheme of Professor Agius. At the same time, in my experience of a clinician, I attempted to simplify the approach to the bipolar spectrum for all the clinicians, because the doctors, I think, need to catch the patient, taking care of our patient and go to the recovery of the patient, so that the approach, I think, needs to be done with the most simplified comprehension, understandable. In this, and I explain again my scheme. I put in the opposite side the acute mania and the unipolar depression, the depressive phase, and inside, between them, all the phases of the kind, the modality of the instability, starting from the bipolar 1, the bipolar 2, the cyclotamine, the group of the mixed states, irritable cyclotamine, mixed dysphoria, agitated depression, the group of the temperaments, subthreshold form, but they are also inside the spectrum. And at the right of the arrow, the modality, the possibility in which these subtypes can develop, or naturally, or induced by substance abuse, or induced by incorrect treatment. This is only a picture in which I draw the modality of the instability. For example, the bipolar 1, crossing strongly the green line, the line of the stability. The bipolar 2, the red line, for example, the mixed dysphoria with this acute point distribution of the instability. You can find also the line of the temperaments, the yellow line, the hyperthymic temperaments that can go to the increased itself going in the phase of the life, in the opposite, the darkest line of the depressive temperament, for example, in the going to the increasing the instability and going down, and so on. This is the chart of the observational study of mine I published some years ago, looking at 423 patients, consecutive new patients, visited in the group of the years. And in this study you can see the modality, the group of the percentage of the diagnosis. You can see that the mixed group, agitated depression, mixed dysphoria, and bipolar 2 are the main percentage represented in this high group of the patient. So that for the clinician it's essential to put the attention to these main symptoms to do a correct diagnosis. The hyperactivity alternating with periods of serious psychomotor retardation, depressive mood or irritability, antisocial behavior, substance abuse, disorder of appetite, suicidal ideation, a sense of despair, anhedonia and widespread apathy, reduced ability to concentrate and mental overactivity. I remark this mental overactivity is essential, above all for the mixed states group. Hyper or hyposexual activity, insomnia or hypersomnia, comorbidity with anxiety disorder, panic, generalized anxiety, OCD, social phobia, and so on. Gastrointestinal disorder, IDASH, and various somatization symptoms. And I shall focus on this last point in the next slides. To assess the patient is very important to put in evidence the bipolar markers. Family history of bipolar, past hypomania episode, more than 3 depressive episodes, seasonal onset, winter, summer or both, cyclothymia or hyperthymic episode, panic, obsessive anxiety symptoms, history of disorder of appetite, and above all, the somatization. The comorbidity, personality, and past history of the patient is very, very important. It's essential to bring out the characteristic temperament of the patient from the beginning of his history on mood disorder, not into the time when we can visit the patient, starting from the time that he was about 20 years old. For example, if I have a patient with a depressive phase, we need to do an important time to investigate past history of the patient and family history. In this past history, for example, we might find an instability before the depressive phase in which we are during the visit, and investigating again, we, for example, might find a cyclothymic temperament, so that you can understand that after this long approach, our final diagnosis can begin not the major depression, but probably, with this example, a bipolar 2. What are the temperaments? The temperaments are very, very important start of the point of the illness. And in order to investigate and understand very well, it's essential to ask the patient a question during the visit with 3 choices. The first, could it be considered that at the age of about 20 years you were a person of a very likely character, hyperactive or extremely cheerful? Second, or a person who always tended to be tense and irritable? Third choice, or a person always tended to be taciturn, solitary, and melancholy. The aim of this question is to identify by positive response to first choice an hyperthymic temperament, the second choice a cyclothymic temperament, the third choice a dysthymic depressive temperament. What are so that the temperaments? They are continuous